So, good evening, everybody in India, and of course, good morning to our two guest speakers from the US, and good afternoon or whatever, wherever, if you are speaking from any other part of the globe. So, welcome again. The INOS brings you another international webinar. Again, two of our star speakers, Dr. Andrew Lee and Dr. Prem Subramanian. It's always been wonderful to have both of these here with us together because of their extremely lively and very, very enlightening talks and discussions, and the clarity of thought that they possess and leave us with such wonderful, clear concepts about the problems that we discuss. So it would absolutely be a pleasure again to hear both of them. And for those, we just wanted to tell we have some extremely great panelists also with us who would be discussing questions and problems of cases which they have seen during the past first wave and now. And we are seeing a marked increase in patients presenting with neuro-ophthalmological disorders. So I'm sure it's going to be an extremely enlightening discussion and will help us in our clinical care as we go along and try to tackle the pandemic and its consequences. And Dr. Andrew will, of course, leave us after half an hour. So we'll run his presentation now and take questions for him. And then subsequently, we'll have Dr. Prem's talk and any questions. And of course, all questions would then be for Dr. Prem to answer. So welcome, everybody. And Swati, if we can load Dr. Andrew's talk.
Yes, sir.
Dr. Rashman, any comments in the meantime?
No, it's as you said, it's always a pleasure to have Andy and Prem with us. And yeah, Swati.
Hello, my name's Andy Lee, and I'm sorry I can't be with you in person. I'm actually Hello, my name's Andy Lee, and I'm sorry I can't be with you in person. I'm actually going to be in London, and maybe I'm there right now. But I'd like to talk to you about neuro-ophthalmology in COVID times. I'd also like to thank the organizers for INOS and the Indian Neuro-Ophthalmology Society for allowing me to speak to you virtually today. So what I'd like to cover for you today is the neuro-ophthalmology of large vessel stroke. And I'm sure the other speakers, including my friend Prem Subramanian, will be covering some of the other issues related to stroke. And if you want to read more about this condition, you can look at this New England Journal of Medicine paper, which came out this past year in 2020 on this exact same topic, large vessel stroke as the presenting feature of COVID-19 in the young. So you really should be thinking about this in young people who have COVID-19, and I'm going to hopefully show you some broad stroke explanations of how this happens. And here's one of my patients who was a 54-year-old Hispanic male who presented with a juxtaposed homonymous hemianopsia. That is, he was a cortical visual impairment after having had COVID-19. Although he had predisposing risk factors of diabetes with a hemoglobin A1C of 6 and hypertension, these were relatively well controlled, and his blood pressure was stable at 120 systolic over 80 on medical therapy. He presented initially with shortness of breath and dyspnea on exertion and was diagnosed with COVID-19 and then discharged home because he seemed to be stable. But then over the next day, he progressively worsened, developed worsening shortness of breath, had to be intubated, and then spent 3 weeks in our intensive care unit. He had elevated D-dimer levels, and we'll talk about why that's important later. He spent 2 months total in a hospital. A full stroke workup was performed. The usual suspects were studied: echocardiogram, carotid Doppler, and hypercoagulable state. And the only thing that was found was the D-dimer elevation, and he was COVID-19 positive. His MRI scan showed bilateral juxtaposed homonymous hemianopsia secondary to these parietal occipital infarcts. And on field testing, he had a juxtaposed homonymous, and I'll show you kind of what that can look like. He went to rehab, he went to low vision, and he slowly recovered, but it took over a year. And so this is what I mean by juxtaposed homonymous hemianopsias. So you can see here on the right, a normal right homonymous hemianopsia from an occipital lobe lesion. It's very congruous. It has a little bit of macular sparing. That's the normal way that we see occipital infarctions. But when you have bilateral occipital infarctions, you get this juxtaposed homonymous hemianopsias, and they come to us in two ways. One is a checkerboard pattern. And so here you can see in the upper left here, this juxtaposed checkerboard pattern, and it can come juxtaposed either at the top of the field, superior or inferior, and it can mimic altitudinal field defect, but really it's a juxtaposed homonymous. So the juxtaposed homonymous pattern that he had was this checkerboard pattern, even though this isn't his exact field. And the juxtaposed homonymous hemianopsia can be a combination of the two, where you have a little bit of a checkerboard, but also an altitudinal one. And that just reflects the severity of the homonymous hemianopsia. So if you have a complete homonymous on the right in this example, and a incomplete on the left, then you'll get this combination of the two, the checkerboard homonymous juxtaposed field and the altitudinal form. And so if you look at this paper from Neurology from August of 2020, you can also get efferent problems. So you can have afferent problems, and large vessel stroke cause homonymous hemianopsia, and you can have efferent problems, and this is cranial nerve palsy. And this is a paper from Dinkin et al. They had 2 patients with COVID-19 who had ophthalmoparesis. On the MRI scan, there was enhancement of the left oculomotor nerve. The right abducens palsy and esotropia was present in the other patient. And in that patient, there was enhancement of the perineal sheath without involvement of the optic nerve substance. And there was enhancement of Tenon's capsule. A chest x-ray, of course, in this patient showed the typical multifocal pneumonia. And so if you look at the imaging from that Dinkin paper, which is fascinating, first you can see an A, you can see the ophthalmoplegia with the abduction deficit here, and you can see on the correlate radiographically in B, where they have this post-contrast enhancement and this T2 change in the left orbit corresponding with the left abducens appearing esotropia. And you can see that over time, you have radiographic change in this patient as well as clinical change. And then, of course, the multifocal pneumonia that was seen in the chest x-ray. So COVID-19 and stroke in the young is something you should be thinking about, especially if you're experiencing the surge in the COVID-19 as India is. And it's thought to be more likely to cause thrombotic vascular events, including stroke, than other coronaviruses or other seasonal infectious diseases, including other viruses. The odds ratio is 76-fold increase in the odds of a stroke in COVID-19 compared to influenza. And the incidence of cardiovascular disease in SARS-CoV-2 positive patients may be as high as 1 to 6%. There are multiple proposed mechanisms, including the hypercoagulable state associated with systemic inflammation and secondary cytokine storm. It's thought that it's a post-infectious immune-mediated response, and that sometimes accounts for the delay, as in seen in my patient, where he was initially fine, but then he was discharged, and then came the cytokine storm and the systemic inflammatory response. Although there are other mechanisms that have been proposed, including direct viral-induced endotheliitis and endotheliopathy, and angiopathic thrombosis with viral particles in the endothelium of the brain. And if you look at our country, but also across the world, there have been multiple regions with high COVID-19 prevalence that show an increase in their year-on-year incidence of large vessel stroke and an increased incidence of cryptogenic stroke, especially in young patients. And so if you look at this other paper, they had 5 patients with less than 50 years old patients who had positive SARS-CoV-2 for COVID-19. Some of those patients had no vasculopathic risk factors, and there was a 7-fold increase in the rate of large vessel stroke in young people compared with the same time period in the year prior. Laboratory studies show very non-specific findings, but suggest a hypercoagulable state. And so you should be thinking about COVID-19 related stroke, especially in young people, and especially if they have no vasculopathic risk factors. The increased thrombosis risk occurs early in COVID-19, but it's a little bit delayed as the process comes on. And the coagulation abnormalities that have been described include D-dimer and fibrinogen, which can be found in patients even with mild symptoms. And the consensus is to start some type of anticoagulation therapy early in COVID-19 before the thrombotic event. And in the multiple series, you can see the N is 26. It can be ischemic or hemorrhagic. And in the young people, 27%. And so if you look at this little cartoon about the COVID-19 complications, we've discussed a little bit about the potential pathophysiologic mechanisms, direct damage to receptors, cytokine-related injuries, hypoxia, or retrograde degeneration. In the acute setting, many different types of inflammatory conditions have been described, and the major complication there that we're talking about today is acute cerebrovascular large vessel disease. And so if you look at this other cartoon, you can see the SARS-CoV-2 leading to hypoxemia, microthrombi, vasoconstriction. There's a lot of research being devoted to seeing kind of how this plays out. There's probably a combination of the two big mechanisms, inflammatory disease and inflammatory cytokines, leading to a procoagulant state, and a combination of thromboinflammation, hypercoagulable state, leading to the large vessel stroke. And so if you look at the countermeasures that have been proposed, it's the standard ones for anticoagulation therapy affecting both the intrinsic and the extrinsic pathway. And you can see here where the various anticoagulations, including Coumadin and the other newer agents, act in the coagulation pathway. And so our major choices are going to be warfarin and the factor 10 and factor 2. Are the areas where we can have countermeasures. And as an ophthalmologist, we don't need to know all this, but we need to know a little bit about what drugs are potentially being offered. And so in COVID-19 patients who are critically ill, there's clearly an incidence of venous thromboembolism that is higher, and it might be as high as 30%. DVT prophylaxis is, of course, recommended, and these patients are often immobilized, as in my patient. He was in the ICU for weeks and then in the hospital for months. And of course, DVT prophylaxis, not just in the COVID-19 population, but in all hospitalized patients. DVT prophylaxis in this setting, however, decreased the 28-day mortality by 20%. And so the thing they're looking for is that D-dimer, and if it's very high levels of D-dimer, or they have sepsis-induced coagulopathy, and there are scoring systems for both of these, the elevated D-dimers are associated, of course, with worse outcomes. And so if you just recall that fibrinogen to thrombin forming that fibrin mesh combination, and that cross-linked fibrin mesh is then degraded over time to other split products, and D-dimer is one of those ways we can measure the thrombosis burden. And so you can see here on the right, the complex activation of the multiple coagulation cascade leading to activated platelets, interaction with 2A, fibrinogen to fibrin, and then it splits with plasmin and the D-dimer. And of course, that's how we approach clot busting, is with these clot busters, of which the most prominent is TPA, and we're not talking about that today, but just to remind you about the D-dimer. And so there's overlapping Venn diagrams about when we should consider oral versus parenteral anticoagulation. It's not your call, but I'm just showing you this to see what kinds of issues are being discussed at the systemic level. And our job is just to come and measure the stroke, and if it's homonymous hemianopsia or juxtaposed homonymous hemianopsia or diplopia, whatever it is, you should know that other physicians on the team are talking about prophylactic measures, including mechanical measures. They're going to be considering oral anticoagulation and parenteral anticoagulation if the person is critically ill or patients already have a DVT or pulmonary embolism. And so there are different approaches to empirically anticoagulating people. I'm not going to go through this whole thing because this is not actually what we're doing. I'm just showing this to you so that you know that somebody is looking at this. And what they are doing is, in our hospital, they are looking at the D-dimer levels. They are considering DVT prophylactic anticoagulation in everyone. They're going to be following those levels. And then they are going to make a decision about therapeutic anticoagulation versus no anticoagulation. And this is a very complex diagram. It's complex on purpose. I'm not showing it to you so that you learn it. I'm showing it to you to show you the complexity of the decision-making for all COVID-19 patients who are adults admitted to the hospital. They're going to get some type of prophylactic therapy, and some of those people are going to get therapeutic anticoagulation. So in critically ill patients, of course, we're thinking about DVT prophylaxis in everybody. There's going to be indications for therapeutic anticoagulation. They're going to be looking at a number of different drugs to consider the anticoagulation. There are other considerations that have to be made in terms of dosage, route, duration, and the drug, and that's not your call. Your call is to the person that makes the call. So they might have an ophthalmic presentation and show up with us, and then we have to make the call to the person who's going to make the decision using some sort of internal or external tree. The other issue I just want to remind you of is the face down position for patients who are with intubated or have COVID-19 that could precipitate venous return problems. It's probably similar to the kind of problems we see in the face down position in spine surgery. And there's risks of increased intraocular pressure and perhaps increased risks of non-arteritic anterior ischemic optic neuropathy. And that's a small vessel thing, and I'm not talking about that today, but I'm sure that that will come up in the discussion. So the COVID-19 large vessel stroke messages I want to leave you with. Number one, COVID-19 definitely increases the risk of stroke, and year-on-year comparisons to prior years show that's going to cause excess mortality and morbidity related to the COVID-19 pandemic. DVT prophylaxis is recommended for all patients at risk in the hospital, and that is the same for COVID-19 patients. Therapeutic anticoagulation, dose, duration, type of drug, Coumadin versus the other options may be indicated in high-risk patients. That's not your call, but it is your call to make the call to that person. D-dimer and other hypercoagulable state workup is going to be performed and can predict the risks. And your docs are going to be following your local hospital anticoagulation protocols, which I have found to be different across different hospital systems, even here in Houston, Texas, let alone across the globe. You should be thinking about large vessel thrombosis in stroke in the young, in COVID-19 patients who have homonymous hemianopsia or who have juxtaposed homonymous hemianopsia. It can occur as the checkerboard form or the altitudinal form, either inferior or superior, or a combination of the two. And the juxtaposed form requires a bilateral occipital infarct. And anticoagulation therapy may be required both during and after they recover from the COVID-19. And I thank you for your time and attention. And I hope to see you live soon once again.
They're using it here, but Dr. Lee, would it have any role?
So the same indications for antiplatelet against anticoagulation are the ways they make that decision. But in terms of the COVID-19 itself, it's usually DVT prophylaxis, and you saw the low-dose heparin algorithms versus anticoagulation. But really, the thing that's driving the decision-making are the same things that drive the decision, antiplatelet versus anticoagulation, in non-COVID patients. So the answer is yes, but the same indications, not just for the COVID-19.
Great. So any questions? Virender, you had a question.
There is an audience question that I put in the chat, so that has just come in from YouTube, I think, one of the.
So just read it out, Digvijay. How do you manage post-infectious cranial nerve palsy presenting a month or more later after COVID-19 with stable general health at presentation? Would you consider systemic steroids?
So there's different levels of evidence, and the COVID-19 evidence base is very small. So I'll just tell you, there's not randomized controlled clinical trial. Level 2 evidence would be meta-analysis or underpowered trial or some sort of quasi-experimental design. Then level 3 evidence is a practice option, could do. That's what this is. It's a practice option, and that's products. And then you have the voodoo and doo-doo. So it's not a must do. It's not a should do. It probably is a could do. It's definitely not a doo-doo, and it could be a voodoo. But you could do this, I guess would be my answer.
And a follow-up question for that has been that please comment on experience regarding post-vaccination cranial nerve palsies.
Yeah, so I'm going to be talking a little bit about some of the post-vaccination things that have been seen, but I would say that to some extent, some of it falls into what Andy was just saying in terms of learning what is chance association versus the fact that it may actually be connected. And so I'm happy to, maybe we'll come back to that after I speak, because I'll be saying a little more about that.
And in fact, that's a great segue, because I'm going to let Prem do all the heavy lifting and take credit for any of his answers that you like. So if you have any compliments, please send them to me. If you have any complaints, however, Dr. Subramanian is happy to answer all those kinds of questions. I'm sorry I can't stay with it right now because I have to go to London right now. But thank you, Rohit, so much for having me, and Rashmin and Prem.
Thank you. Thank you.
Lift it, man.
Yes. Thank you, Andrew. So we hope to see you again for the next edition. And Prem, we can take your talk and then maybe have the questions on together in the end.
Sure. That sounds good. So let me go ahead and get my presentation up here. Fabulous. Okay. So thank you again for inviting me to...
to stop, everybody, could you please keep your... mics on mute while Prem is speaking so that we don't get any background sounds coming. Thank you. Sorry, Prem. So now
no problem at all. No, thank you. And so my talk is titled Vision Disturbance with COVID-19 Infection. And this, I think, will complement nicely what Andy Lee was just telling you about some of the large vessel stroke issues in patients with this condition. I have no relevant financial disclosures to make to you. And what I will cover is in 3 sections: preventing vision loss during the pandemic, vision loss associated with COVID-19. And Andy just alluded to the fact that some of this is association and some of this may be a more concrete connection between the two. And I think maybe in the discussion, we'll have more time to cover that. And then finally, vaccine-associated vision issues, which wisely already one of our audience members raised as to what can we expect to happen as we vaccinate millions, tens of millions of people, hundreds of millions against this disease. So Dr. Lee suggested to you that many of the things that we see from infection with SARS-CoV-2 results from immune response. And it's worth taking a step back and just quickly looking at this complex diagram, but focusing maybe on a couple of things that help us to understand why we see so many neuro-ophthalmologic things and neurological things with infection of this respiratory virus. We don't see it to the same degree with other respiratory diseases. So macrophage infection occurs, macrophage recognition by the virus when it invades the body. And that leads to CD4 positive T cell activation, release of a tremendous number of cytokines. And again, Andy alluded to the cytokine storm, and we'll talk a little bit about that. But much of what I will discuss today may be more related to direct infection, but we just don't know. But that amplified immune reaction is the body's way of then creating antibodies, activating ultimately B cells, producing antibodies and neutralizing this virus. But host cell infection also drives some of it. So this is a diagram here of the intracellular process inside a typical host lung cell, for example. And double-stranded RNA is something that doesn't exist in our cells. And so double-stranded RNA itself, which is produced in the process of viral replication, stimulates the immune system, sensitizes TLR3, leads to further cytokine release of protective antiviral proteins actually into the extracellular space. And so it's this balancing act. And so one of the issues that arises when there is excess of cytokines that has already been discussed was, of course, the large vessel stroke that can occur. But what else happens in the process of this immune response, and what else should we consider? Well, before we do that, I think as neuro-ophthalmologists, one of the issues that arose for us is that immunosuppression is something that we frequently use in patients with neuro-ophthalmic disease. So conditions like neuromyelitis optica, like MOG-associated optic neuritis, myasthenia gravis, giant cell arteritis, all of these patients may be on long-term immunosuppression, and of course, multiple sclerosis, right? And so early on in the pandemic, my colleagues and I at the University of Colorado published a paper in the Journal of Neuro-Ophthalmology looking at some of these issues. And we looked at a couple of things. So who's at risk, right? We think that immunosuppression decreases, of course, your immune reaction. That's what it's supposed to do. But does it really increase the risk not only of infection with SARS-CoV-2, but does it increase the severity of outcomes from COVID-19? And so is the immunosuppression risk cumulative? So if the patient is already older, if they have diabetes, if they have some other condition, is the pandemic going to change our equation? What's the risk of the severity of their disease? Are they more likely to have mortality? But then what is the risk of disease exacerbation? Conversely, if we reduce their immunosuppression. So if we say we're no longer going to treat you with mycophenolate mofetil or with azathioprine, and we take the risk that their underlying disease will worsen, that they may have neurological consequences in the setting of NMO. Remember, patients who have aquaporin 4 positivity, when they get an exacerbation of their NMO, they can have severe disability that puts them in a wheelchair or may even kill them. So how do we balance these risks? And I point you actually to a very nicely written counterpoint by two of my colleagues, Mark Buffard and Michael Levy at Harvard Medical School. This was just published in the Journal of Neuro-Ophthalmology. And they go into some of these issues in a little more detail. But one interesting point that they raise that I think we should all consider, and that you all are very well versed with, as I'll come back to, is the risk of corticosteroids. And I'm not talking about corticosteroids in diabetic patients right now, but the risk of corticosteroids in some of those conditions that I just mentioned. Should we use it in a patient who has typical optic neuritis, not COVID positive? None of these patients at this point, when you're considering them, are COVID positive, but rather, are you going to increase their risk that they are going to acquire COVID-19 during the time that they are treated with corticosteroids? So typical optic neuritis, or even a flare of atypical optic neuritis, we're not giving high-dose corticosteroids for very long. But some patients with myasthenia gravis, some patients with sarcoidosis, they are maintained on chronic moderate dose corticosteroids for long periods of time. Corticosteroids are cheap. They have many side effects, but particularly in my country, when patients don't have good health insurance, and perhaps in India, where they may not be able to afford the more expensive medications, they may be kept on long-term steroids. And that produces a real risk, and something that we should reconsider, because the steroids may increase their risk of a poor outcome from COVID-19 disease if they then ultimately become sick. And then our elderly patients who have giant cell arteritis, you don't have so many in India, but should we be keeping them on the 1 year or more of corticosteroids, or should we transition them quickly to another agent? We have things available like tocilizumab that potentially could be used to mitigate that risk of immune suppression. So these are some of the issues that we raised early on in the pandemic that I think we still don't have good answers to. And I'd be interested in the panelists' views on use of steroid in some of these conditions. Again, on patients, we're talking about pre-infection with COVID. These are not patients who have COVID infection. We're talking about how do we minimize their risk of disease exacerbation, their underlying disease, while not increasing their risk of developing COVID-19 disease. So I'll move from there to talking about vision loss in COVID-19 patients. So again, Andy talked about stroke, and in particular occipital lobe stroke, and to some extent double vision, that I will cover again in a different manner. But a recent review, again, Journal of Neuro-Ophthalmology, I direct you to the Journal of Neuro-Ophthalmology website. We have been offering for non-subscribers access to COVID-19 related resources. And so many of the papers that I'm going to discuss today, you can go and look them up in greater detail, spend some time reading them, and see how they might relate to the patients that you are caring for. But vision loss in COVID-19 patients has been described in a number of different scenarios. So dacryoadenitis, conjunctivitis, and You are, of course, familiar with the idea that there may be viable virus on the ocular surface, and conversely, that COVID-19 could be transmitted through the ocular surface if droplets land on the ocular surface, and the use of eye protection, particularly in high endemic areas and in the care of patients with COVID-19 in the hospital or other settings, certainly makes a lot of sense. There was a somewhat odd paper that was published in JAMA Ophthalmology out of China, where they suggested that patients who routinely wear eyeglasses might be at lower risk for developing COVID-19. And this received a lot of press. But getting back to what my colleague Andy was saying before, there's a lot of interesting and sort of correlation being made without really great epidemiologic data. And this was a study where they looked at rates of myopia and suggested that the rates of uncorrected myopia in patients who were hospitalized was different than patients who were out in the community, and that therefore people in the community were more likely to be wearing glasses than the people who were in the hospital, and they were at higher risk. You have to be careful about making conclusions like that. Other things have been reported: tonic pupil. I talked about preventing myasthenia gravis exacerbation, but myasthenia might occur in the setting of COVID, and then vitritis has been described. But from the neuro-ophthalmologic perspective, what has been reported? And so optic neuritis has definitely been seen in the setting of infection with SARS-CoV-2 and with the full COVID-19 disease. And I think it's important that we keep these two things separate as I go through this, because some of the things I will describe to you, patients were COVID positive, so positive for PCR testing for SARS-CoV-2, but they didn't have the characteristic respiratory, GI, or other symptoms that go along with the disease. But in these cases, and this is one in particular that was reported of bilateral sequential optic neuritis in a patient who was older than typical, in their 50s, who had COVID-19 disease and then developed this sequential optic neuritis. You can see on the left a T2 coronal image with thickening more of the right than the left optic nerve, and here enhancement of the right more than the left optic nerve. This was taken when the second eye was involved, and that's when the patient sought attention. But this was after their infection. So was this directly related to viral involvement, viral infection of the nerve, or was this a post-inflammatory condition? Was this an immune-mediated reaction? And it may be more likely to be immune-mediated because other forms of optic neuritis have been reported after infection with this disease, within weeks of infection. So Andy Lee reported a case of a new onset aquaporin 4 positive optic neuritis in a patient who had COVID-19 a couple of weeks prior. There's a report from my colleague Vivek Patel of a MOG positive optic neuritis about 2 weeks after infection with COVID-19 disease. And both patients recovered, of course, from their COVID-19 disease before developing the optic neuritis. So is this specific to COVID-19 disease, or is this an autoimmune process that is being revved up in the healing phase from COVID-19, and this is why patients are developing it? We still don't know, because this last case, the one that I've showed you with the photographs, this was a double seronegative, did not have NMO or MOG antibodies. So we are still learning again what causes this. Orbital inflammation has also been described. Now, this is completely distinct from the mucormycosis that unfortunately is another epidemic along with COVID-19 in India right now. This is from a pediatric or a teenage population, 2 patients reported by my colleague Roger Turbin early on in the pandemic in the northeastern United States. And this here is a 12-year-old boy who developed typical signs and symptoms of orbital cellulitis. He was tested for COVID-19 as a routine because he was being taken to the operating room for debulking and biopsy because there was concern that his disease was progressing. The MRI and CT, you can see, are showing significant abnormalities here in the supratemporal area of the right orbit, some lucency. There's definite involvement of the maxillary and ethmoid sinuses here, and then even some enhancement of the dura. And this is in a boy, a 12-year-old boy, who had had no prior history of any sinus disease. And similarly, this was a 15-year-old Black boy who presented again with typical orbital cellulitis, no respiratory signs or symptoms. He had no normal chest X-ray and chest CT. He was febrile, but this was thought to be because of his orbital cellulitis. He also had COVID-19 testing as a preoperative precaution before being taken to the operating room. This is, again, early in the pandemic, but he tested positive. And again, you can see that there's this extensive maxillary sinusitis, some heterogeneous opacity on CT scan. There's thickening of the mucosa. And there is, again, this dural enhancement intracranially with maybe some subdural fluid collection. So the direct responsibility, again, of the COVID-19 infection in these two individuals for this typical presentation of orbital cellulitis is still not entirely known. But I would encourage you, when you see patients, particularly now during this unfortunate second wave, who do not have the pulmonary complications, they don't have diabetes. Of course, it was considered that this could be mucormycosis or some other fungal infection, but in both cases, all cultures and biopsies were completely negative for any infectious source, for any sinus infectious source. And so ultimately, this was thought to be an inflammatory response. So again, I encourage you to consider that inflammatory type of orbital cellulitis in patients who are presenting with this picture, but it could be related to viral infection. And then finally, there have been, and this is a very nice review that was just published in the JNO on afferent and efferent complications of this disease. There have been further reports of conditions like papilloedema. Now, I have seen this in my clinical practice. This is the typical kind of papilloedema that you might see in a pseudotumor cerebri syndrome. These particular photographs were from a patient who had actually lost 40 pounds, so the precise reason for development of the papilloedema is not clear, given the previous talk, as well as what we know about the hypercoagulable state that can occur in patients with COVID-19. Venous sinus thrombosis has to be excluded, but this is a different patient here who also presented with papilloedema after COVID-19 infection. And you can see that there's typical distal transverse sinus stenosis, but there's no evidence for an actual venous sinus thrombosis in this particular case. There have been reports out of the UK, as well as in the United States, of patients who have gained weight during lockdowns or be working from home and having to care for their children and being under great stress, and so eating more than they might and gaining weight. And I have definitely seen this in my practice, a recurrence of pseudotumor cerebri in patients whose disease had gone into remission, and then new diagnoses in patients who have gained 20, 30 kilograms over the course of several months while they have been stuck at home. And I hope that you are not seeing this same kind of epidemic of pseudotumor in India, or that you won't see this developing as the second wave starts to come under control and patients start being able to visit you for outpatient needs once again. Andy alluded to this case of diplopia in COVID-19, but this is a different case of a patient, again, with perineural optic nerve sheath enhancement, as you can see here, who developed COVID-19, was in hospital. She had diplopia with what was thought to be a right sixth nerve palsy pattern. This was a post-discharge examination done by telemedicine about 2 weeks after she was let out of the hospital. And you can appreciate that on abduction, or on right gaze, I should say, her abduction is absent in her right eye. But again, there's this bilateral perineural sheath enhancement without enhancement of the optic nerve itself, and she had no afferent visual complaint. So again, the precise relationship between the COVID-19 infection and this diplopia is not clear. And let me show you a couple of other cases where I think it helps us to understand that this may be more autoimmune mediated rather than being from infection itself or from infarction that might be produced by the hypercoagulable state. This is another case that was reported of a 32-year-old previously healthy man who developed COVID-19, was hospitalized. During that hospitalization, within a couple of days, was noticed the acute onset of diplopia. And after recovery, he was examined by a pediatric ophthalmologist 5 weeks later, had a complete abduction loss of the left eye, had a greater than 60 prism diopter esotropia on left gaze. There was no other cranial neuropathy. The patient was otherwise recovering well. But what was curious about this is that the authors showed that there is atrophy of the left lateral rectus. And we normally only see this months or even years later after a patient has had a chronic sixth nerve palsy. So was this actually an infarction of the muscle? The patient never had pain, and muscle infarctions are usually painful. But it, again, shows us what we still don't know about how patients are developing their visual symptoms during an active infection with COVID-19. And in this same light, maybe synthesizing some of what my friend Dr. Lee was telling you, this was a patient who presented to us, and we have published this case, a man in his late 60s who had hypertension, he had diabetes, he had previously been treated for cirrhosis, and he presented with typical respiratory failure and was found to be positive for the COVID-19 virus. He was hospitalized, placed on typical respiratory support. He was given dexamethasone because of his lung disease, chest x-ray showing typical ground glass pneumonia. But within a couple of days of his admission, actually within 24 hours of his admission, he noted severe and complete vision loss in his left eye. And when we were consulted to go see him, you can appreciate that in the left eye here, the optic nerve is somewhat pale, but there is also a cherry red spot. It is difficult, I think, on this screen to see that there was box scarring in the retinal arteries or arterioles and some Hollenhorst plaque. And this was consistent with a central retinal artery occlusion. And in addition, so he was found to have a complete right internal carotid artery occlusion from the origin up to the ICA terminus with some recanalization or recollateralization. But he also, on an MRI, was found to have restricted diffusion within the anterior aspect of his left optic nerve, which, this is flipped, sorry, and he was then noted to have some watershed infarcts as well within the brain. So he was diagnosed with a CRAO, but where he synthesizes these other cases is that he also had a sixth nerve palsy on the right side. And that sixth nerve palsy demonstrates to us that he had an inflammatory process as well, because there was enhancement of his sixth nerve on the MRI that was done. And you would not expect enhancement of the sixth nerve from an infarction. You would expect DWI positivity, but not enhancement. So it again tells us that there can be multiple mechanisms that are going on here in producing the vision loss. So in this particular case, we see that there is contribution both of inflammatory and thrombotic events that are leading to the vision loss with COVID-19 infection. This is a table that I put up, not because I'm going to go through it in detail, but rather because I want to point out to you the number of different mechanisms that are being considered for why patients might lose vision loss in the setting, might lose vision in the setting of this disease, and the number of different neuro-ophthalmic conditions that have been described. Again, I encourage you to read this review for greater details because I don't have time to go into all of this. But what I would like to just take a moment to do is to go over maybe just a couple of theories that have been raised as to why patients develop these problems. And so again, the COVID-19 infection, we talked already about hypercoagulability, and I'll leave that alone. The endothelial dysfunction may be what causes stroke. The cytokine storm, I think, is responsible for some of these conditions, like the optic neuropathies that we are seeing. I did not talk about the multi-inflammatory syndrome that is being seen sometimes in children in particular, but that multisystem inflammation has to be considered as well. I think there is still not great evidence for direct neural invasion by this virus. It has been shown in a few autopsy studies that there is some neurotropism of the COVID-19 virus, that it may be able to bind to neurons, but it's not clear that in the majority of patients it's actually crossing the blood-brain barrier, the blood-retina barrier, and causing these conditions. I think it is more likely that it is this autoimmune process that is leading to the optic neuropathies and cranial neuropathies that we are seeing in our patients who have this disease. And again, I'll be interested to know the opinions of the panelists if they have any other evidence or other experiences that might help us to understand the different mechanisms by which our patients are having these problems. I'd like to finish up by talking about vaccination and the vision issues that we have seen in these contexts. So just very recently to me, a 28-year-old woman was referred at 17 weeks of pregnancy. She had had her first dose of the Pfizer vaccine, had a headache for a few days, some periocular pain, but she experienced no vision loss at that time. However, when she had her second dose 3 weeks later, as is the normal course with this vaccine, she developed a persistent headache, light sensitivity, and some blurred vision in her right eye. And initially, she does have a history of migraine headache, so she thought this was migraine headache. Since she was pregnant, she wasn't really eager to take any medication or seek any medical attention. And it was only when she had this persistent blurry vision that was interfering with her work as a software engineer that she decided to go and see an optometrist. The optometrist evaluated her, found that she had vision that was 7.5, so mildly reduced in the right eye, normal vision, left eye, no RAPD. She had normal color vision, her optic nerve, retina were all normal in appearance. He saw that she had some chirpy. And because she had pain, because she was a 28-year-old woman, he suspected that she had optic neuritis, and that is why she was referred to me as a neuro-ophthalmologist. But in fact, when I saw this patient, she had, again, no RAPD. She had normal color vision, but this is what I saw. And so she had, as you can see on the left here, she had 2 to 3 plus anterior chamber cell, but better appreciated on the slit lamp photos is that she had large and small keratic precipitates. So a granulomatous anterior uveitis. There was some anterior vitritis as well. And in the posterior segment, while the retina was completely normal and RPE looks normal, her choroid, this is not an EDI OCT, you don't need that, this is just a spectralis OCT of the macula, her choroid is quite thickened. And in consultation with one of my uveitis colleagues, we realized that this is very likely to be a post-vaccination uveitis. And he has been seeing several of these cases, and they typically are self-limited. They are treated with topical and, if needed, subtenons or oral corticosteroids. But in general, these patients will do well. And you see one, then you see them again. This is a next patient, a 70-year-old man who was following up with me a week later for diplopia. And I had been following him for diplopia in the setting of a prior meningioma. But he reported to me that he had received the Johnson & Johnson vaccine, so the single-shot vaccine, and he had noticed within a day that he had some decreased vision in his right eye. He said it got quite severe, but he didn't seek attention because he wasn't too worried about it, and he figured it would get better. And sure enough, it had gotten much better by the time he saw me, but you can see he developed a little bit of retinal scarring. He has some residual thickening of his choroid, and in his anterior segment, he had resolving anterior uveitis. It was bilateral, but highly asymmetric. The previous patient, I should mention, had a bilateral uveitis. And then finally, I'd like to leave you with 2 cases of optic neuritis that we are in the process of reporting after COVID-19 vaccination. Both occurred in patients in their 60s with some other comorbidities, prediabetes and some hypertension, but otherwise fairly healthy individuals. And this was a woman who received the Pfizer vaccine, and within a day or two of her second dose, she developed severe vision loss, painless in her right eye. And she was found to have light perception vision in her right eye with a relative afferent pupillary defect. You can appreciate that there's marked swelling with hemorrhage of the right optic nerve and that the left optic nerve was normal. So she was tested for COVID-19. She was negative. She was tested for other inflammatory markers like ESR, CRP for giant cell arteritis. She was tested for other entities like MOG and NMO, and all of these were negative. And she had an MRI that, as the arrows show you, showed a marked enhancement and hyperintensity on T1 and T2 respectively of the right optic nerve, consistent with a right optic neuritis. She was hospitalized, treated with 5 days of intravenous corticosteroid, and 5 weeks later, her vision had improved significantly to about 2100, but it was still markedly impaired. And then this was seen at a different institution. At my institution, this 67-year-old man presented with NLP vision in his left eye about 2 days after his second dose of the Moderna COVID-19 vaccine. You can appreciate that his right eye also has significant conjunctival injection and chemosis, and this was somewhat unexpected. So he had some pain, some orbital pain, conjunctival injection, chemosis. His right eye vision was slightly reduced at 20/40, and again, his left eye was no light perception. And so he was hospitalized. He again had COVID-19 testing. He was negative for the virus. He was tested for inflammatory infectious markers, MOG, NMO, typical things that caused inflammatory disorders, sarcoid, syphilis, all of this was negative. And he had an MRI, and his picture, remember back to that patient who had diplopia, who had enhancement of the optic nerve sheaths? The short arrows are pointing to orbital as well as optic nerve sheath inflammation, and the long arrow points to enhancement of the retrobulbar optic nerve on that left side where he was no light perception, consistent with an optic neuritis, but also an optic perineuritis kind of picture, a more orbital inflammatory picture. Again, after vaccination, this is not infection with the actual virus. This patient was also treated with 5 days of intravenous corticosteroid. He had some improvement to light perception, maybe hand movements, but not a very significant recovery of vision. So just briefly, I think this leaves us with some topics for discussion amongst the panelists of what is the direct role of SARS-CoV-2 in the pathogenesis of these various neuro-ophthalmologic conditions. Is it actual virus infection? Do we need to give antivirals to patients who present with this kind of picture? Or is it treating the cytokine activation, the immune response that occurs in the vast majority of patients who have this disease? What should we do about immunosuppression in patients who are living through periods of pandemic surge like you are right now in India? And then finally, what should we be on the lookout in our patients who are receiving the COVID-19 vaccine as we try to emerge from this situation? And again, I point you to this COVID-19 resource on the Journal of Neuro-Ophthalmology website. Encourage all of you to make use of it because I think there's a lot of great information there that's of particular concern to ophthalmologists, not just neuro-ophthalmologists, that can help you when you see patients like this. And I thank you for your attention.
Thank you, Prem. Wonderful, an excellent presentation, and of course, you highlighted the very questions we, were thinking right at the beginning of the program about what to treat and what are the associations, whether they are, if any, and of course, for those patients who are on immunosuppression, steroids, because of their long-term neuro-ophthalmological or other systemic disease. So are they at increased risk, and how do we alter or manage? So maybe we'll have some more questions. In the meantime, there is a question in how early after vaccination do you see these patients who present with neuro-ophthalmological complications?
So the ones I have seen are presenting within days. So I think that it is, again, it's not going to be delayed. It's not weeks later. They are showing up within 2-3 days after the vaccination, or in retrospect, even if they don't present to me at that time, they say that their symptoms had started within even a day or two of the vaccination itself. And I think there was a question as well about enhancement of optic nerves or enhancement of the cranial nerves in those patients. And so far, there has been some evidence for enhancement on gadolinium-enhanced MRI. So I think it again points to this autoimmune process that is in those patients.
My question would be that if they come so quickly after vaccination, you're not expecting the immune response to kind of, move in so fast?
No, it's a great question, Rohit, and I think it's we're going to learn whether it is actually a specific response to the agent itself. So, in other words, to the mRNA that's in the Pfizer or Moderna vaccine, or to the other antigens that are in the J&J or AstraZeneca vaccines, or whether it's the adjuvant that is stimulating that very early response. And the Moderna vaccine in particular has a very strong adjuvant. And so My personal theory is that it is more likely the adjuvant. Every vaccine has an adjuvant, right, to stir up the immune system and to increase the immune responsivity. So I suspect it's the adjuvant and not the actual viral elements that are causing this, because you're exactly right. You wouldn't expect the body to be producing antibodies and such for some days afterward.
So, sir, why one eye is affected? Why not the other one?
Well, so that's a great question, right? And I think it gets, so with the uveitis that I showed you, those patients had a bilateral asymmetric uveitis in the patient who had the optic neuritis, right? It was just one eye. And I think that's a broader question that is interestingly, we think that any type of optic neuritis arises from a systemic inflammation, right? If a patient is aquaporin 4 positive or MOG positive, that antibody is circulating throughout the body. So why don't we always see optic neuritis in those situations as a bilateral process? And, whether you think it's the deity who protects us, and protects one eye, whether you think it's just luck, we don't exactly know why it is that it's a unilateral rather than a bilateral process.
Similarly, in cases of optic neuritis also, we normally see one eye is severely affected and the other eye is either mildly affected or it may not be affected at all. So I was just thinking, why, if it is an immune modulated system, inflammation, then it should have been in both eyes, or one eye should not be totally free of inflammation and the other eye is severely affected when we don't see any predisposing factor in that eye also.
Right. No, again, I think that's a very, it's a very valid point. It's an interesting one. And I think it applies to more than just optic neuritis in the setting of COVID. It applies to optic neuritis more broadly. And that's just a lack of our understanding maybe of what some of the local risk factors might be in a particular optic nerve on one side that makes it vulnerable to attack from the autoimmune process.
One more thing, you had shown that orbital inflammation in one of the COVID patient. So, because in COVID patients, normally we keep the patients prone for quite a long time, for hours together. So, could it be a orbital compartment syndrome rather than direct viral infection? And why it was only in one eye? The other eye was fairly normal.
Sure.
Because,
Yeah. So if you're speaking about the optic neuritis patients, the one who've had it in the setting of COVID, that was some weeks later. That was a couple of weeks later. So, and that patient had not been prone positioned. They were not ventilated. They did have an oxygen requirement in hospital, but were not prone positioned. None of the patients I showed you were in prone positioning. So I don't think it was an orbital compartment syndrome. But again, the asymmetry, I can't give you a great explanation for the asymmetry because it was not a local difference between the two sides, maybe pressure on one side compared to the other.
Yeah. And one more thing, pseudotumor cerebri, how frequently do you come across in these patients? Because these patients, they are otherwise hypertensive or diabetic sometimes. And even sometimes, even with the normal non-obese patients also, we do see increased intracranial tension in these patients.
I think there are a few different categories. There are some who may have some CNS inflammation and they develop a pseudotumor cerebri picture because of that. There are definitely patients who have a venous sinus thrombosis, and that leads to their pseudotumor cerebri picture, and that's irrespective of BMI. And the ones I had mentioned were not, again, directly COVID infection related, but rather the situation surrounding the pandemic where people are stuck at home, they are eating, they are not exercising, they're under stress and they're stress eating. And so they gain weight in that setting. And so it's an indirect effect of COVID that they then develop a more typical pseudotumor cerebri associated with obesity.
Okay, thank you.
So the question one is there that how frequently do you see MOG or NMO positive, and do you think it is possibly cross reaction with the antibodies generated for COVID-19?
that's an area that we're looking at right now. So one of my colleagues here at the university is a neuroimmunologist who is trying to get serum from these patients to look at exactly that question, because theoretically, it could be that there is some cross-reactivity, that the antibodies to this virus actually are acting in a similar way. But the other theory, getting back again to immune activation, is that because you have this inflammatory storm that occurs, that a patient who had a predisposition to produce MOG antibodies or produce NMO antibodies is going to make more of them in the setting of a generalized immune activated state. And that's an area of active research right now to try to tell those two things apart. And that, again, we again have to be careful, right? Because I think especially with the vaccine-related events that I showed them to you because I think we need to be aware of them. And I think the vaccine-associated uveitis is very clearly vaccine-associated. And the two cases may well be of optic neuritis. But we're vaccinating, at least in this country, millions of people every day. Well, out of those millions, incidentally, some of them are going to develop sixth nerve palsy. Some of them are going to develop optic neuritis. And so we have to take some careful epidemiologic data to see, is it really an increased number of patients, or is it just that because we're vaccinating everyone who walks in the door, that yes, they have vaccine and sixth nerve palsy? And that's an important question that will take some time to answer.
I guess exactly that's what he started with, Andy, when he joined. So that's what he was saying, that you need to put in the very very hard criteria of association of a disease rather than just an incidental finding. So as you're saying, we kind of vaccinating lakhs, millions all over the world. So there is a possible chance that somebody was like just presenting with a sixth nerve palsy, presenting with one of the features, and we are kind of associating. So I guess we'll have to wait to see how things move out. Is the incidence of a particular condition more than what you would expect in the general population of that age group or say of that risk group? So that would probably give us more as we go along with the vaccination process, and of course with the disease. Yeah. So. Right.
And in fact, we already saw that with the J&J vaccine in the United States and with the AstraZeneca vaccine, right, with this possible association with venous infarction. And again, it's not resolved because the numbers are so small against the population being vaccinated.
Dr. Ashwini, you raised your hand?
Yeah, yes, sir. I just want to ask one question. One patient traveled for vaccination from one place to other. Meanwhile, he got vaccine, and on second day he developed fever. On the next day, then it might be because of the adverse effect of the vaccine. But eventually, the patient developed COVID. Now the patient admitted. Patient and given oral steroid and IV steroid as per the protocol because he was diabetic. Patient came to me on around 4th week after recovery and quarantine, with diminution of vision. Then the right eye has optic neuritis like picture with vision of like hand movement on PL plus. Now I'm confused whether it is because of vaccine, because patient has vaccine and patient had travel history. A patient admitted into the ward, whether a patient is given low molecular weight heparin also, whether it is because of the COVID complication or because of the vaccine or because of the low molecular weight heparin, on whether to give IV steroid at this point. The protocol 1 gram is advisable. Whether patient is a diabetic, so the blood sugar is also fluctuating because during the admission procedure they have sugar spike up to 315. So what to be done in such scenario?
Yeah, a difficult question. What I would say is that the fact that it was about 4 weeks after the initial presentation makes it less likely in my mind that it is vaccine associated.
The patient complained of diminution vision, and in hospital they advise MRI because it cannot be done because patient is COVID positive.
Yeah. So it's possible. Yeah. Okay. Thank you. No. Okay. So there are two possibilities, right? And you might be able to tell them apart now by getting MRI, because there could, if this was optic neuritis, then there will probably still be some T2 hyperintensity in the optic nerve, even a few weeks later. If this was infarction, like the patient I showed you who had the restricted diffusion within the optic nerve because of thrombosis, 4 weeks later now, you might see some optic atrophy, but I would not expect that you would see T2 hyperintensity like you might see with optic neuritis. So that might be one way to try to tell those two things apart, ischemia versus inflammation. If in either case, though, if the patient lost vision while in hospital with acute COVID-19, it's been 4 weeks, and the benefit of giving him IV corticosteroids now is probably quite low. Since he already received them, he didn't receive high-dose steroid, but he was on steroid, as you said, because of the pulmonary issues, as we do with these patients. So I'd be, again, trying to balance the risks out. I would be less likely to give him steroid because of concern for making his sugars worse, because of lesser likelihood that he's going to recover because it's now weeks later since onset of vision loss.
Thank you.
Just a question related to motility and not vision loss. Just to go, myasthenia also has been reported as a consequence of COVID. So again, is it likely that it's possibly associated, or it's just by chance? Because we have been seeing a couple of patients a month or so post-COVID, and your interventions and management, would it be similar, or would we look at something else?
So I'm willing, because we still don't know exactly what triggers diseases like myasthenia, and for many of these things, we think maybe a viral infection predisposes you to it, right? So I'm willing to believe, at least for now, that there might be a little more of a direct relationship between COVID infection and onset of myasthenia in some patients who are already predisposed to getting it. That said, I don't think it changes anything that we do in terms of the treatment. I would not treat that patient any differently than I would some other patient with newly diagnosed myasthenia gravis. I don't think there's any evidence that we need to treat it differently, because again, the ones that have been reported that probably that you've seen, it's not in the acute infectious stage, but rather later on. Now, there have been, I think, Miller-Fisher syndrome has been reported. And, clearly that is a post-viral syndrome, even, or post-infectious syndrome in other patients or in other infectious conditions.
Dr. Anirudh, you had a question?
So actually, just wanted to share some data as what you also pointed out. I had personally monitored maybe around 20,000 Covishield vaccines, and surprisingly, we didn't notice even a single case of any visual deterioration. And in fact, I have data for more than almost 2.25 lakh patients, all in the age group of generally around less than 50 years of age, and not even a single case of visual deterioration. So I will actually agree with your point that it could be these optic neuritis or cranial palsies could be incidental findings, and we are maybe trying to relate it to some vaccination. So that is just my point.
Did they have any other symptoms? Sorry, Dr. Prem. Did they have any other? I mean, of course, they didn't have visual deterioration, but were there any, of course, non-significant? We would expect them to have fever, myalgias. But was there any serious adverse effects of the vaccination?
Of maybe around 2.25 lakh patients in the under 50 years of age group, we just possibly had one case of stroke, CVA, and so that was it. So that was the only single case, and we all had Covishield vaccines, around 2.25 lakh patients. So that was the only thing, but no visual symptoms as such.
Yeah, Dr. Prem, sorry.
No, I was just going to say that one of the reasons that we reported the two patients, or reporting the two patients that we did, is because they were atypical for having optic neuritis, because they are both in their late 60s, where we typically don't see optic neuritis. But I'm happy to hear that in a more typical population where you might see optic neuritis or other such things, you did not see it. That's great to hear.
One more thing is the possibility of optic neuritis with mild subnormal vision cannot be ruled out, because the patients in India, they may not be taking it seriously. Even if there is a mild blurring of vision, so majority of the illiterate patients, they will not notice it. And secondly, in the early stage of optic neuritis, we usually, because of the guidelines given by the authorities, usually we do minimal fundoscopic examination, and even visual field testing also is being done limitedly. So that is why we might be missing these patients also. Optic neuritis, they are, of course, they are suffering, they are recovering also, and the patients may not be noticing it because the physician or ICU managers, they are more worried about the pulmonary conditions, and they are worried about that life problems rather than the visual problems. So it might have been neglected both from the patient point of view as well as from the doctor point of view.
Fair enough. Fair enough. That's a very valid point. Just to stir it before we take more questions, just to stir it to pediatric optic neuritis, we've been seeing an increase in the patients in our second wave in India are much larger, although they say probably the proportions are similar. But pediatric optic neuritis. So, did you see any? Now, in fact, vaccinations are there in the US for younger children also. So teenagers are now being vaccinated. So any upsurge or any likelihood or association with COVID-19 and or the vaccination for pediatric?
Yeah. So we've been fortunate that we haven't seen quite as many pediatric cases that you are seeing in India. And the vaccination now is available for 12 and up. In that group, I have not been seen a surge in optic neuritis or visual dysfunction. And I think that it may be, I would be suspicious that the cases that are being seen in India, I don't know if you're testing for MOG or if they have an ADEM-like picture, but that would be something I would look for in those individuals, because I think that may be what is happening, just given the fact that children are more likely to develop that kind of condition in the setting of an acute illness.
Great. Dr. Meenakshi, you have a question?
Yeah, no, I actually wanted to ask Dr. Prem as well as share two. We had two patients. One came, in fact, today, who had a 20-year-old who got a Covaxin just 2 days back. And he has developed a total visual loss on one side. Incidentally, the only positive history he gave was that he has a history of ventricular septal defect, for which he was not on any treatment. And in fact, 1 day before the thing, he seemed to have felt that there is a little, before the vaccine, so I don't know whether it's unrelated to the vaccine or it's just that the vaccine accentuated the thing. His vision 1 day prior to the thing was 6/9 for vaccine. And I've had another lady who is a young nurse who was on ATT. She got clearance that she can take a vaccine. She took a Covishield in Feb. And within a day, her vision fell more so in one eye. And she also had anterior uveitis. She was given IV methylprednisolone. But surprisingly, we did not find any fundus changes. There were some visual field changes, but the OCT has remained normal till date. So I would like your comments, Dr. Prem.
Sure. So on your first patient, that's an interesting point, that the vaccine, if this patient was already tipping into having optic neuritis, maybe the vaccine made it worse. And that may be a non-specific effect, not directly related to the fact that it's a COVID-19 vaccine, but it could have been if they got a rubella vaccine or a tetanus vaccine, it may have done exactly the same thing. And so, we've seen this every year when influenza vaccine is given, there's a little bit of an uptick in cases of optic neuritis, for example, right? And I think that, again, it's a non-specific immune response to that. And so with your second patient, it would be interesting to know if the choroid was thickened, if this was a vaccine-associated anterior uveitis, and it sounds less like it was an optic neuritis if the OCT was the optic nerve was normal throughout, and that the decreased vision and visual field defects, whether they were maybe from a little bit of choroidal inflammation or even retinal inflammation that was subclinical, that may have produced that. So that would have been an interesting thing to see in that case.
My question there was that could it have been that the ethambutol toxicity could have got accentuated? She was on ATT, on a very high dose ATT for abdominal tuberculosis for almost a year.
I'd be a little less suspicious of that, only just because of the time course. If did the visual field changes reverse after some time, or did they stay?
They did.
Yeah.
They did.
So I'd be a little more suspicious that it was the uveitis itself, since she had the anterior uveitis, that it can produce more of a pan-uveitis that can be subclinical. And I'd be a little more suspicious that that was the case rather than an accentuation of any ethambutol toxicity on the eye.
So you're saying that it's not really optic neuritis?
I'm a little less convinced that it's optic neuritis in that case.
She did have color vision loss, and there was a bit of RAPD.
Yeah. So it could have been a bit of a mixed picture then. Absolutely.
I've had another patient who came presented with a myasthenia gravis-like picture, and like if you look at him, he was perfectly fine. Only when I did the test could I make out that there was drooping. How have you seen the response of such patients with the treatment, as Dr. Rohit also asked?
Yeah, so far I don't think we have any evidence that they respond any differently than patients who present with new myasthenia from other causes. I think that we have to collect data on that. We'll learn that probably over the next few years, but at least in the short term, I'm not aware of any major differences. I don't know if anyone else has noticed the difference in the patients that they are seeing, but we have not.
Thank you.
Dr. Varshni, you have a question? I think we'll just take one or two more, and then we'll probably let Dr. Prem manage for the day. Yeah, Dr. Varshni. You're muted at the moment.
I just wanted to say that it's just a feeling that rather than seeing patients post-vaccination, I feel we are seeing more patients with optic neuropathies who have had asymptomatic COVID-19, in the sense that when we check them, the RT-PCRs are negative, but their COVID antibodies are positive. And I don't know if they're associated. We're not seeing the post-vaccination patients, I think, at the same rate at which they are reported. And I don't know if these asymptomatic COVID-19 positive with antibody positive, whether they are associated or not associated, I'm not really sure, considering the percentage of patients who are positive now.
Right, and that's always going to be the big question, right? Is if you would have to have a comparison population that is antibody negative, and that's going to become a little bit harder to find right now, just with the exposure to the virus being so high.
I think, Murli, you want to say something?
Yes, Dr. Rohit. Actually, I had one patient who presented. This patient was 45-year-old, and this patient had COVID-19 3 weeks back, and he presented with sudden loss of vision in the right eye. So he was a diabetic, and his sugars were out of control, and he had pansinusitis, but there was no orbital invasion noted on MRI. So I referred him to the ENT surgeon. So what would you consider? I mean, I guess you're not seeing so many of mucor as we are seeing, but what would...
So it was not mucor. I mean, the ENT person ruled out mucor.
No, the patient was lost to follow-up.
Oh, okay.
But there was no orbital invasion. And
no orbital invasion, but it could be, peri-infectious inflammatory that may be responsible for the optic nerve involvement. I mean, again, you need to look for, I think Dr. Prem would answer probably, MRI to look for any optic nerve enhancement and see for any involvement of the optic nerve, I guess, or any motility defects, if any.
There were no motility defects.
Okay, so...
Yeah, I mean, the differential, just like Rohit said, would be, it would either be a peri-inflammatory process from the adjacent inflammation, but it also could be, if it is mucor, you could have a silent infarction within the optic nerve as you affect those feeding branches that are adjacent to the sphenoid sinus, optic canal, and high quality neuroimaging might be able to tell you the difference, but certainly I'd be concerned that this was a fungal infection that then led to the vision loss.
Great, wonderful. I think we should. Dr. Sujata.
Can I ask one question to
okay. Yeah, Dr. Kumudi, I think we'll take just one. Yeah, Dr. Kumudi, let's take just one last question. And I think we'll probably do this again in a couple of months when we also become wiser, and I'm sure Dr. Prem will have more information to share. Dr. Kumudi, yeah, you can just we'll take the last question and then probably we'll call it a day or night.
Just I want to know from Dr. Prem, is there any difference in the visual outcome in an optic neuritis caused by the vaccination from the one which you see after the COVID infection?
Sure. So that came a couple of different ways. Dr. Virender had asked as well, and the answer is that the few that we've seen, the recovery has been poor. I don't know, again, if that is a direct consequence just of the severe inflammatory response. And I think Virender shared that they had some experience where it was a similar issue, that the visual recovery was poor in the setting of a potential vaccine-associated optic neuritis. So whether it's specific to this vaccine or whether it's just that such patients have such a severe inflammatory response that it causes a lot of optic nerve damage and you just can't recover from that, that would be my theory, that it's a severe inflammatory response and that's why they have poor visual recovery.
Great. So I think we are much wiser after this wonderful 1.5-hour session with two of our top speakers. Of course, we'll have to catch Andy again sometime and put him through the rack like we did for Prem. But I think it was wonderful. And like I said, probably as our understanding and our experience with the disease and the vaccination process evolves, we would be in a better position to probably, answer many of the questions that still probably do remain unanswered as we evolve in our knowledge and our understanding of the disease and the effects it's happening all over the body. And in the second wave, we've actually seen so many more things happening that we actually, did not see in the first wave. So more features that we are seeing. So I guess it would be great sometime again that we have. And thank you, Dr. Prem, and of course, Andy, who is not here at the moment, and of course, the panelists for a wonderful discussion, for great questions, and for a wonderful interactive session. So thank you, everybody. Good day, Prem, and good night to everybody here in India. And stay safe. That's the only thing I think, the most important message that we can give. Thank you.
Absolutely. Be well. Thank you. See you next time.
Bye.
Bye.